Good evening, everybody. We're getting into Chapter 8 and Chapter 9 now. And so in Chapter 8, the entire chapter discusses the different bones and bone markings. The majority of this you're going to have to know for the lab practicals and for the bone quizzes. But I do want to go over some of the bone markings that you do have to know and some characteristics of bone, the types of bones and stuff, okay? And then we'll get into Chapter 9. So Chapter 8 is a very minimal amount of materials. Bone markings themselves are just regions on the bone that have certain characteristics, such as a bump or a smooth area that allow other bones or other materials like ligaments or muscles to attach and articulate. So Figure 8.1 goes over all kinds of different bone markings. The ones that we typically use, we use the condyle when we talk about the femur. We have a medial and lateral condyle and then epicondyles. We use the head, so the rounded region of the proximal epiphysis, a trochlea, a grooved region. So we have a trochlea on the humerus. You can see it right there. We'll talk about alveolus. These are pits that we find in the maxilla and the mandible. This is where we have our tooth and jaw joint. We talk about fossa. Fossa are shallow depressions. We talk about, I'm trying to go through, I talked about that. We use the word process a lot, where muscles attach to bones. We use the spine, especially when we're talking about specific bones, like the spinous process on the vertebrae. Greater trochanter, lesser trochanter, I'll use those. Those are specific to the femur, and they're used to identify part or the region of the femur so that we can give shots to patients. Oh, sorry. Tuberosities, we talk about, the main one I talk about is the tibial tuberosity. And I'm trying to think, I don't think I talk about any other tuberosities. Canals and foramen, they're very similar. So it's just a passage through the bone. Foramen is a rounded passage, whereas a canal is more of a narrow passage, but they're really the same. So I don't really change those. I use those interchangeably, okay? So the skeletal system is separated into or classified into two groupings. We have an axial region and then an appendicular region. The axial is the head and the torso. Appendicular are the appendages. So you can see the axial here, all blue or green, whatever you want to call it. And then there's your appendicular skeleton. A lot of times I ask questions about, is this axial or is this part of the appendicular skeleton? So it's important to know the difference. All right, we're going to watch a video on the skull. You have to know all the skull bones already, and you have been working on those. So I'm going to watch a video with you right now on the skull, okay?
The human skull. The human skull is made up of 8 cranial bones that surround and protect the brain, and 14 facial bones that form the underlying structure of the face and support for the teeth. With the exception of the mandible, the bones of the skull articulate with each other through joints known as sutures. Throughout the skull, holes known as foramina serve as passageways for blood vessels and nerves. Bones on the surface of the skull encase the brain, protect sensory organs, and serve as attachment sites for the muscles of the head and neck. These bones include the occipital bone, parietal bones, temporal bones, and the frontal bone, as well as the nasal bones, the zygomatic bones, the maxilla, and the mandible. Other bones become more visible only when looking inside the skull. The sphenoid bone makes up the anterior base of the cranium. It is a butterfly-shaped bone with a central body and two pair of laterally projecting wings. These wings form portions of the orbit. The body of the sphenoid features a depression known as the sella turcica, which houses the pituitary gland. Located between the orbits, the ethmoid bone makes up a portion of the cranial floor and also the roof of the nasal cavity. An inferior projection, the perpendicular plate of the ethmoid bone, forms part of the nasal septum. The crista galli projects superiorly from the ethmoid bone and serves as the attachment point for the falx cerebri, a dural fold. Extending laterally from the crista galli is the cribriform plate, a perforated area through which the olfactory nerves pass. The two L-shaped palatine bones form the posterior third of the hard palate, part of the nasal cavity, and a portion of the orbit. The small, thin lacrimal bones make up the anterior portion of the medial wall of each orbit. A groove known as the lacrimal groove helps to form the nasolacrimal canal, which contains a duct that allows tears to travel to the nasal cavity. The vomer is an elongated, plow-shaped bone that forms the inferior and posterior part of the nasal septum. The internal and external skull bones articulate precisely, forming an intricate structure perfectly suited to its functions.
All right. A few other bones that are located in the skull are the auditory ossicles. The auditory ossicles are very small. They're the smallest bones of the body. And you can see them here. We have the malleus, which is kind of a hammer-shaped bone, an incus, which looks kind of like an anvil, and then a stapes bone, which kind of looks like a stirrup. And so the common terms are the hammer, the anvil, and the stirrup. You probably heard that when you were growing up. The technical terms or the medical terms are the malleus, the incus, and the stapes. And what these bones do is, as soon as my clock stops dinging, all right, what these bones do when sound waves travel into the ear and hit the tympanic membrane, they cause the malleus to vibrate onto the incus, which vibrates onto the stapes, and the stapes sends the vibrations to the inner ear. It's kind of cool. So these bones are very important, even though they're super tiny. The hyoid bone is a very small bone located just inferior the mouth. So if you go just inferior, it's above the larynx, so you can see the larynx right here. There's your hyoid bone. The hyoid bone is the attachment site for our tongue, as well as for muscles that attach to the larynx, or the attachment sites for the larynx muscles, as well as ligaments that help to hold bones to bones. The hyoid bone is the only bone of the body that does not articulate with any other bone. And then in the fetal skeleton, the skull has fontanelles. So we say fetal skeleton, but I should say infant skeleton as well. Fontanelles are soft spots on the baby's head, and they're composed of dense regular connective tissue. This holds the bones together and eventually will close up. These soft spots or fontanelles will close up and produce the nice hard skull that we have. The soft spots serve two major purposes. They allow the baby's brain to grow. So as the brain grows, the head grows with it. So the brain doesn't get smashed in that head inside of the cranial cavity. But it also allows the baby's head to mold in the birth canal so that the baby can get through a lot easier. So there are 4 sets of fontanelles. There are two sphenoidal fontanelles. There are 2 mastoidal fontanelles. There's a posterior fontanelle and an anterior fontanelle. And so here you can see there's the anterior, there's your posterior, here's one of the mastoidal fontanelles, and there's your sphenoidal fontanelle. You'll have a mastoidal and sphenoidal on the opposite side as well. The vertebrae are the next portion of the axial skeleton that I like to talk about. There are 5 divisions of the vertebrae. Each division is identified, or you know the divisions by the name of the vertebrae themselves. So we have cervical, then thoracic, then lumbar, then the sacrum, and then coccyx. Almost forgot the word sacrum for some reason. And so here you can see all of the vertebrae that we have. The C's stand for cervical vertebrae, and we have 7 cervical. T stand for thoracic. There are 12 thoracic. L stands for the lumbar. There are 5 lumbar. S stands for sacral. There are 5 sacral that are all fused together to form the sacrum. And then the coccyx is CO1 through CO4. And again, they're all fused as well. So when I talk about the vertebrae, to remember the numbers, I always think of you eat breakfast at 7, lunch at 12, and dinner at 5. And that will help you to remember cervical, thoracic, and lumbar and the number of vertebrae. As the vertebrae move from the most superior, which is your cervical vertebrae 1, down to your lumbar vertebrae, the vertebrae get bigger and bigger. And then once you hit sacral vertebrae, they get smaller and smaller again. So it kind of goes from big, or from small to big to small. So you can see the vertebrae in the body, and there are different curvatures of the cervical as well as thoracic and lumbar vertebrae. Here you can see the cervical groove even better, and the thoracic groove and the lumbar groove, okay? So there are some anomalies of the spine that I talk about. The first is called kyphosis. Kyphosis is an exaggerated hump on the thoracic vertebrae. So the thoracic vertebrae has a natural curve, but when that curve gets so large that you produce that hunchback, that is known as kyphosis. And what happens is as people age and slouching, when people are slouching and as we age, the vertebrae start forming a new curve, basically. And because of osteoporosis, the bones start losing their strength, and so they start pushing together. And this forms that little bump, and it actually causes people to get shorter in height. So when you see those little old ladies that are kind of hunched over, well, they probably were taller at one point, and if they could stand straight up again, they'd be taller. So one thing you can do to protect yourself is to hold your shoulders back thrust your chest out and stand proud, basically. So be very watchful of your sitting position. So no slouching and stuff, okay? Here you can see an individual that has kyphosis. So this is the back of that individual. And then you can see from a side view, there's the back of that individual. So post-op, that individual has no kyphosis. She's standing very straight. The vertebrae are all in a line. Typically, what they will do is they will put the vertebrae in a line, and then they will put some type of a metal brace in to help hold it that way. Lordosis is an abnormal curvature of the lumbar, or not abnormal, exaggerated curvature of the lumbar vertebrae. And we see this often with little babies. Babies always have this abnormal, or not abnormal, but exaggerated curve. Whereas in children and young adults, we typically don't see this. You do see it in individuals that have gained weight. And so here's a pregnant person, and so she has this nice little pregnant baby belly, and she leans back to kind of offset that baby belly so that she's got a center of gravity right over her feet, over her legs and feet. So this is known as lordosis because when looking at royalty, they often would stand with their chest out, and I'm sorry, I keep hitting buttons, with their chest out, and they'd kind of have their back bent, showing that they were the bomb diggity. But it actually can cause damage. It can cause pain, and I know that treatment of lordosis is a little bit different. I had a student who had lordosis, and so he had to go to physical therapy, and they basically put warm compresses on his back, and they massaged his back, trying to push his vertebrae back in place, which is kind of crazy because every time I've been to physical therapy, they made me exercise hard, and it was not fun. But, it is what it is. And so now here is the probably most common or the most well-known spinal curvature, and this is called scoliosis. So scoliosis is a lateral curvature of the thoracic vertebrae. So you see here's a very severe lateral curvature. Here you see that lateral curvature again. And there are different treatments for scoliosis depending on how severe. They have braces that they can use. They also, what the braces do is the brace will help to straighten your back slowly. They can also do surgery where they, again, will use a rod to help hold, put your vertebrae back in order, and then a rod that will help to hold that vertebrae in place. So when you think of the brace, think of like braces for your teeth and moving your teeth. The brace is actually moving your vertebrae back in line. So it's going to be a slow process, but when it's done, you're going to have a very straight spine. And so there you see that nice straight spine that you're hoping for. The first and second vertebrae have special names, and you do have to know these. So please make sure that you know these. The first vertebrae is known as the atlas. The atlas is what holds or what articulates, I'll say that, with the occipital bone at the occipital condyle. And what the atlas does, or not what the atlas does, I like to, the reason it's named the atlas is because just like the atlas of the world holds maps of the world, the atlas of the vertebrae holds your head, which contains your brain. So it's really important, all that information. The atlas, when it articulates with the occipital bone, it produces a joint movement that allows us to say yes. So every time you're nodding yes, it's your atlanto-occipital joint allowing you to do that. Here's the atlas. Oh, geez Louise. Here's the atlas. These facets here, these facets are, are what articulate with the occipital bone, the occipital condyles. These are cervical vertebrae, and so all cervical vertebrae have certain characteristics in common. If you look right here, you can see a little hole, and over here you see a hole, and then there's a very large hole here. These holes are known as foramen. So all cervical vertebrae have 3 foramen. They have 2 transverse foramen, and then they have the large foramen this is the spinal foramen that allows the spinal cord to run through. The atlas sits on its axis, just like the world sits on its axis. So the axis is the second vertebrae. It's the only other vertebrae you have to know by name. So the axis and the atlas articulate together, allowing us to say no. Shake your head no. Okay? And so here is the axis. The axis has this large toothy joint or toothy projection known as the dens or the odontoid process. And here are the facets where the atlas and the axis sit together. So here you can see that joint right here. And this structure here is a ligament. Ligament is dense regular connective tissue that connects bone to bone. And so this goes right around the odontoid process and allows this atlas and axis to articulate, allowing us to turn our heads without falling off. And again, there's one, two, oh, this is the same, I'm sorry. There's one transverse foramen, there's the 2, and then there's the 3rd right there. So you have 3 foramen and all cervical vertebrae. A herniated disc occurs when between the vertebrae we have fibrocartilage that decreases the stress of the joints. So, and decreases pressure. So whenever you jump up and down or use a lot of pressure, give a lot of pressure on your vertebrae, the fibrocartilage acts as a shock absorber, so it takes a lot of that pressure away. If the fibrocartilage, a portion of that fibrocartilage gets damaged and bulges outside of the vertebrae, it can actually cause pinching of the spinal nerves, and it can be very painful, and that's called a herniated disc. So herniated discs can occur in the cervical, the thoracic, or the lumbar regions. In the cervical region, it typically causes pain in the upper limbs or the neck. The lower back pain is associated with lumbar herniated discs, but it also can cause sciatica, which is a very painful disorder. And a lot of you have probably felt your sciatic nerve pain, especially if you've ever had a child when you're pregnant. The pressure can actually push on the sciatic nerve. The excess weight can cause pressure on the sciatic nerve, and that can cause your entire lower limb to not be able to hold your weight, and you could almost fall. So chapter 9 is all about the joints. And we have a lot of different joints. They are identified both structurally and functionally. A joint, in a nutshell, is just an area where two bones meet and articulate, so where they come together. Depending on the structure of the joint, let me say it this way. The structure of the joint will determine how it functions. So will it determine what type of movement occurs. And so structurally, we classify joints either as fibrous joints, which are composed of dense regular connective tissue, cartilaginous joints, which are composed of either fibrocartilage or hyaline cartilage, or synovial joints. So a fibrous joint is a joint that has no joint cavity and has little to no movement between the bones. A cartilaginous joint also has no joint cavity, and it again is going to have little to no movement between the bones. A synovial joint has a joint cavity and has so it has a joint cavity. It has a lot of protective ligaments and tendons, and has a lot of movement between the bones. We can classify joints functionally as well. So structurally, you have the fibrous and the cartilaginous joints. These joints are going to have either no movement or little movement. If you have little movement, then you have an amphiarthrosis. Amphiarthrosis has very minimal movement. If you are a cartilaginous joint that is an amphiarthrosis, then you're going to be composed of fibrocartilage. So all amphiarthroses that are cartilage, that are composed of cartilage, are composed of fibrocartilage. Fibrous joints are still composed of dense regular connective tissue, but if they're an amphiarthrosis, they have slight movement. A synarthrosis is an immobile joint. You can have you could have dense regular connective tissue, fibrous joints that are synarthroses. You can also have cartilaginous joints that are synarthroses. If you're a cartilaginous joint and you're a synarthrosis, that means you are composed of hyaline cartilage. So the only joints that are considered freely movable are your synovial joints, and a freely movable joint is known as a diarthrosis. And these joints can move in all directions, or well, not all of them, but they can move freely within the bones and within that joint cavity. So on page 298, there's a table that goes over both the functional and structural classification of joints. You do want to know this because I always have a table that I put on the exam where you have to fill in the blanks. And I give you different types of joints or different classifications, and you have to fill in the other parts. So I told you that depending on the type of joint and what it's composed of will determine its functionality. So the range of motion of a joint is going to be dependent on how movable it is. Well, no, how do I want to say this? The range of motion of a joint is going to be dependent on how stable it is. That's maybe a better way. A more freely movable joint is going to be less stable than a less movable joint. So if you have a very immobile joint, like a synarthrosis, it's going to be a very stable joint. It's not going to probably, you're not going to have a lot of slipped bones in that type of joint. Whereas if you have a very mobile joint, it's less stable and it's more likely going to come out of socket. Does that make sense? I hope, because I guess since I'm here in my house and you're probably in your house, if it doesn't make sense, you can't really ask. But what you can do if you don't understand this is write it down and come to class with it, okay? So let's look at each of these joints a little bit closer. Fibrous joints are composed of dense regular connective tissue. They can be either immobile or slightly mobile. There are three types of fibrous joints: gomphoses, which are your tooth and jaw joint; sutures, which are the joints that you find in the skull and in a lot of your facial bones; and then syndesmoses, which are found between the antebrachial region bones and the crural region bones. So the tibia and fibula and the radius and ulna. So here are the different joints. A gomphosis is a synarthrosis, which means there's no movement between the bones. The tooth and the jaw have a periodontal ligament that holds them in place. And that's really important because you don't want this joint. If this joint became more movable, the tooth could fall out very easily. A suture is another synarthrosis joint. There's no movement between these bones. In this coronal suture, in the squamous suture here, in the lambdoid suture there, or the sagittal suture, you have no movement between those joints, between those bones. So it's a synarthrosis. Now, between the radius and ulna, between the tibia and fibula, we have a syndesmosis. So this, again, dense regular connective tissue, but there is slight movement between these bones. They can be squeezed together slightly. This bone can move around this bone slightly, so you can twist your arm, supination, pronation, which we'll show you in a little bit, okay? Cartilaginous joints also have no joint cavity. They can be synarthroses or amphiarthroses, so immobile or slightly mobile. The different types of joints are associated with different types of cartilage. So any immobile joints are known as synchondroses, and they're composed of hyaline cartilage. Any slightly mobile joint is called a symphysis, and it's composed of fibrocartilage. So here we have a synarthrosis between the epiphysis of our long bones and the diaphysis of our long bones. So this is where that epiphyseal plate is going to be found. And so this is hyaline cartilage. And here, between the ribs and our sternum, we have costal cartilage. And again, this cartilage holds the vertebrae and the ribs and the sternum together. There's no movement. These are composed of hyaline cartilage. Here we have intervertebral discs, and there's your your pubic symphysis. These are both types of symphyses, and they're composed of fibrocartilage. There's slight movement within these joints. The last joint, and probably the most common joint of the body, and most well-known joint as well, is called the synovial joint. So this is a freely movable joint. Bones within these joints tend to have some space between them. All of these joints are diarthroses, and they all have certain characteristics. They all have a capsule. I should say they all have an articular capsule with a joint cavity. They have synovial fluid produced by epithelial cells within that joint cavity. They have articular cartilage that covers the ends of the bones so that when the bones do touch, they have cartilage that protects them. They are held in place by ligaments as well as tendons that hold muscles. And they have a good blood supply and they have a good nerve supply. The capsule itself is double layered. The outer layer is dense connective tissue that holds the bones together, dense regular connective tissue making up that ligament. And then the inner layer is composed of epithelial cells that have a basement membrane of areolar connective tissue. The epithelial cells produce synovial fluid. I talked about what the articular cartilage already did. It covers the ends of your long bones, and its function is to reduce friction. It absorbs shock. So like when the bones compress, it takes some of that shock away, some of the damage away, so that the bones don't get hurt. There's just a bigger picture, okay? Synovial fluid has multiple functions. Not only does the articular cartilage absorb shock, synovial fluid absorbs shock. Synovial fluid also helps to nourish the cartilage cells. Remember, cartilage is avascular, and so it has to get its nutrients from something, and so it gets its nutrients from the fluid surrounding it. And then synovial fluid is a lubricator, so it lubricates the joint itself. Ligaments and tendons are composed of dense regular connective tissue, and their function is to, so for ligaments, they connect bones to bones, and they help to strengthen the synovial joints. Tendons connect muscle to bone, so they allow bones to move. They're not part of the synovial joint at all, but they do help to stabilize those synovial joints. And this is the same picture. Okay. Some synovial joints have bursa that surround the ligaments so that they can like protect those ligaments as well, so you don't have inflammatory responses around the ligaments or the tendons for that matter. Bursa and tendon sheaths surround your ligaments as well as your tendons in areas where there's a lot of excess friction. So areas where you have a lot of bones that are being held together, and there's lots of fine movements like in your feet and in your hands and wrists. You're going to have these special tendon sheaths that just protect those ligaments and those tendons. And then fat is a packing material that just is put into the synovial cavity in areas where there's nothing else there, so it just kind of acts as a packing material. So here's a fully functional synovial joint. This is figure 9.5 in your textbook, okay? Here you can see tendon sheaths around these tendons that attach the flexor muscles to the hand, or to the fingers and to the wrists. These actually help to keep the muscles and the muscles of the hands from getting too stressed out, and you don't get tendinitis easily. But we also have running through these sheaths nerves. And so if these ligaments or tendons get inflamed, they can actually compress nerves, and that's what causes some of the problems with our hands. The specific one that we talk about typically is carpal tunnel syndrome. So if we're looking just at synovial joints and their movements, all synovial joints are freely functional. They're free movable. So they are diarthroses. But some synovial joints are more movable than other synovial joints. So we can have synovial joints that move on only one axis. They're going to be the least movable of our synovial joints. We have biaxial synovial joints, which can move in 2 planes. And then we have multiaxial that can move in multiple planes. So if you hold your wrist and you move your hand up and down, you can feel the bones there kind of moving a little. That's a uniaxial joint that makes up the wrist joint, okay? So I shouldn't say that. The wrist joint itself isn't uniaxial. The bones within the wrist, the intercarpal joint between the carpals, is a uniaxial joint. A biaxial joint is a joint that can move on 2 planes. An example of a biaxial joint is take your fingers, hold your hands up, and now spread your fingers out like you want to make your hand as big as possible, and you're showing like 5 fingers. And now bend your fingers forward like you're starting to wave. So you can move your hand, your fingers, out and forward and back up and out and back in and forward. So that's biaxial. A multiaxial joint is a joint that can move on multiple planes. So an example would be your shoulder joint. You can move your shoulder in multiple planes. A better example of a uniaxial joint, as I was talking, I thought about it, and I was like, a really good example, the interphalangeal joint. So between the fingers, or between the bones of the fingers, we can bend our fingers like you're doing, waving with just one finger. That's a single uniaxial joint. Your elbow joint is a uniaxial joint. So joints can move on, or can be, all synovial joints are freely movable, but some are less movable, like I said before. And so from the least movable to the most movable, we have planar joints, which are uniaxial joints, hinge joints, which are uniaxial joints, pivot joints, condylar joints, saddle joints, and then ball and socket joints. So let's look at a planar joint. A planar joint is a joint between bones that just move past each other just slightly. So intercarpal and intertarsal are the only 2 types of planar joints that we have in our body. Hinge joints, though, are joints that that move on one axis only, and our interphalangeal joints, our elbow joints, our knee joints, those are all hinge joints. They move in one axis. They can decrease the range of motion, or I should say, decrease the angle or increase the angle. That's really what they do. A pivot joint is a uniaxial joint that just rotates around one set point. And so the example here is a pivot joint around the dens of the axis, and allowing us to say, no, that's a uniaxial joint. It moves around one axis. A condylar joint is a biaxial joint. So this is between the metacarpal and the phalanges of our fingers, and actually So if you take your hand and you move your fingers apart, move them back together, bend them forward. That's two different angles, so that's biaxial, okay? Saddle joint is also biaxial, but it's slightly bigger range of motion than your condylar joint. So with the saddle joint, the only two saddle joints we have in our body are the carpal metacarpal of the thumb, and the thumb can move towards other fingers and away from other fingers. It can move back. It can almost move in a complete circle. So it has slightly more movement. It's still considered biaxial, but it does have slight more movement. The most freely movable joint then is our ball and socket joint. And we have a ball and socket joint of our shoulders and ball and socket joint in our hips for our acetabulo-femoral joint is our hip joint, and then the glenohumeral joint is our shoulder joint. So here we can see all the joint movements that can occur. This is figure 9.6 in our textbook. So we're going to talk about the range or the types of motions, and then I'm going to close this lecture off, okay? So the types of motions that you can have with our synovial joints, we can have gliding motion where the bones just kind of glide past each other. That's what you see in a planar joint. We can have angular motions where we have like a uniaxial joint. Hinge joint is an example of an angular motion joint. We can have rotation where your glenohumeral joint allows your shoulder to rotate around. And then we have some special movements that we'll talk about, okay? So a gliding joint, I've already talked about this. This is the least movable of all of our joints, and it's just bones sliding back and forth. This is what we see between the carpals and the tarsals of our body. Angular motions, flexion, extension, hyperextension, lateral flexion, abduction, adduction, and circumduction. So flexion is decreasing the angle of a joint. Take your arms, put them out, and now bend at the elbows towards the body. That's your flexing. You're decreasing the angle. Now bring your arms back out. You're extending them. So now I want you to use your neck. Now I want you to look down. Flexion. Go back up. Extension. And now put your head way high up. Look at the ceiling. You're hyperextending. Lateral flexion occurs when you bend to the side with your torso. You bend to the side. Maybe you're trying to touch your toes sideways. Maybe you're doing side bends to lose weight. It doesn't matter. It's all the same. Abduction is moving the body regions away from the body. So if you're taking your leg and moving it away from the body, that's abduction. If you bring it back, you're adding it back. So if you're abducting something, you're taking it away. If you're adding it back, you're adding it back. So it's adduction. And circumduction takes your flexion, extension, and adduction, abduction, and puts it into a movement. So it's kind of like you are making a circular motion at the most distal region of your body. So take your arms out and now move them forward, or no, I want you to start flexing, but then I want you to rotate them at the same time and bring your arms around and just kind of move your hands in a circular motion. That's circumduction. You can do that with your arms. You can do that with your legs. You can do that with your fingers as well. I've already talked about these. I'll let you read these on your own because I've talked about them. So there you can see flexion, extension, hyperextension, lateral flexion, abduction, adduction. There you're seeing adduction and abduction. adduction of the arm, of the leg, of the hand, of the fingers, and adduction of all of those as well. And then circumduction. Here you can see circumduction. Rotation is movement pivoting along an axis. So there's lateral rotation. So if you stand up, and now I want you to put your leg out, and I want you to rotate the knee laterally. So it's facing away from the body. And now I want you to rotate that same knee medially. So turn it towards the body. Supination and pronation are what our hands do. When your palms are facing up, you're supine. So it's like, think about it, supination, you can carry soup in your hands. Pronation, you dump the soup. Supination, you're carrying the soup. Pronation, you're dumping it, okay? So there you can see rotation, lateral and medial rotation, and supination and pronation. Some special movements, we have depression and elevation. Open your mouth, put your jaws, your mandible down. That's depression. Bring your jaw back up like you're chewing. That's elevation. So there we're using our shoulders. Depression, elevation, depression, elevation. That's like a dance move people do where they're shrugging their shoulders and like kind of to a beat. They're like boom, 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 boom. And you can kind of get into it while you're depressing and elevating your shoulders. Dorsiflexion and plantar flexion. Dorsiflexion is turning your ankle towards the body. Or I'm sorry, what am I saying? I'm doing eversion and inversion. Dorsiflexion is pointing your toes towards the front of the body. Plantar flexion is pointing your toes towards the back of the body. So if you're standing on your heels, then you're dorsiflexing. If you're standing on your toes, you're plantar flexing. Inversion and eversion. Inversion, you're rotating your foot towards the middle of the body. Eversion, you're rotating your foot away from the body. Protraction and retraction. So protraction is moving anteriorly. So your jaw moves forward. It's how some people dance, like a chicken. They go forward, protraction, backwards, retraction. Protraction, retraction, protraction, retraction. You can just keep doing that. And then with the shoulder shrugs, you look like, really cool on the dance floor. So think about that. The last one is opposition and reposition. This is something that only certain animals can do. So those of us who have opposable thumbs. Opposition is touching the opposite fingers. Reposition is going back to the beginning. Okay, and so there is a video that I'll play here, and then I'm going to stop it at the end of this video. Okay. This is a really awesome video, I'm not going to lie. It's one of my favorites. Of course, all my videos seem to be one of my favorites, right? All right, here it goes.
Man, I'm showing y'all the movements. Listen to me. Man, I'm showing y'all the movements. That's what you'll see. Anatomical movements. Anatomical movements. Yeah. back up in the mix like that to show you what I mean so you won't fall flat. These terms that you need to get you up to speed, the words are at the bottom, you can listen and read. First things first, you should lift your wrist, then decrease the angle, something like this. When you do that, you could call it flexion. Increase the angle and that's called extension. Now, put your hands by your side, rotate your thumb so they face outside. When the thumb points out, lateral's how it's facing, and when it points in, it's medial rotation. Movements, listen to me. Man, I'm showing y'all the movements. That's what you'll see. Anatomical movements. Anatomical movements. Put your arms out and move them round. Circumduction's moving round. There's a few terms left for a discussion. Arms by your side, moving away is abduction. Now keep your arms out, and when you move them back in, that movement there is adduction. These next two movements you're really gonna love. You can do them in the club, looking like a shoulder shrug. Remember this song next time you're with the patient. Lifting up your shoulders is called elevation. Opposite of that is what's next in our lesson. Lowering your shoulders, that's called depression. Last one is supination with the palms up. Pronation's when it's facing down, that's what's up. Movements. Anatomical movements. Next up is something funky, sorta neat, cause we gotta talk about some movements of the feet, yeah. That's how your feet be working, roll your foot so it angles out, and that's eversion, yeah. And when you roll it back in, that movement there is inversion. The next term you'll learn is something you use often. It's the movement you'll do if you're ever moonwalking. If you're picking up just what I'm putting down, lift your foot up and point your toes towards the ground. If you're unsure of the term and left guessing, bottom of the foot is plantar, the move is plantar flexion. Put your foot down and leave it like it's resting. Lift your toes off the ground, it's dorsiflexion. And that's it, all the terms you need. Just remember this song and you're sure to succeed.
So I hope you enjoyed the song as much as I did. I love it, so it's just something I love. The last things we'll talk about some joint disorders, and then we're going to talk about specific joints that I want you to know. So I'm going to turn this off now and upload it to your Canvas page. Have a great night. Bye.